Thanks for joining us today for our webcast on managing a conversion and meaningful use attestation simultaneously. Your phones have been automatically muted for the duration of the presentation today. Should you have any questions, please do not hesitate to post them to our Q&A panel. We'll then be taking those and compiling them and posting the answers to all of your questions following today's presentation. So just to start off with introductions, my name is James Quill. I'm a consultant here at Galen Healthcare Solutions. I'm on the professional services team. I'm currently working as an analyst, and I've been in healthcare IT for a little over 2 years.
I'm sorry, if someone's talking, this is Sin, sorry, if someone's talking, I am not hearing you right now.
All right, hello. Hi, I'm Christy Mitchell, and I'm a senior consultant here with Galen. I've been focused these last few years on implementations, upgrades, conversions, and most importantly, meaningful use. I've been in healthcare IT for just about 10 years. I've spent time in a local hospital and on the floor at a smaller local family practice, and now I've spent almost 5 years here at Galen.
Conversion platform. I have also spent a lot of time developing our internal conversion platform called Galen ETL to help standardize our process, regardless of the system that we're converting from or converting into. I've been at Galen for 2 years.
Okay, so let's get started. We wanted to open this webcast and introduce topics that we believe will assist you in meeting meaningful use throughout your conversion. It's certainly a big topic, and we've been questioned on by a lot of our converting clients. So we wanted to cover the topics that you need to think about, things to plan for, and what our recommendations are going to be throughout the process. To start, we'll have Jimmy cover a lot of the overview of the conversion process. He's going to cover the types of conversions that we support, what to consider when scheduling a conversion, and most importantly, the big items that come into play when creating a project plan. We also want to add in the technical perspective, so we have Drew covering some of our best practice recommendations and all the data types that you will have to be familiar with. So leading next will be myself. I'll be covering the planning considerations for your attestation and meaningful use. What exactly is your ability to attest for MU while also managing a conversion? It's going to be wise to think about some of these things before kicking off a project that you might not be ready for. So we'll ask questions like, do you have resources in place that have done this before? Does everyone know all the necessary fields to populate with the appropriate information? Do you have configuration experts for both EHRs that can communicate effectively about all the MU requirements? Is your project manager experienced with other conversions, and do they understand the complexity of MU reporting? There's actually a lot to think about. So we're going to discuss the technical aspects of the conversion and the attestation, where to store your data and for how long, what do your states require for data storage, and most importantly, how do you get the calculated data to be used in your final submission to CMS. You're also going to notice that we'll pause for a few minutes throughout the presentation to ask a few poll questions. Drew will be leading those, and we hope that you can take a second to assist us so that we know our audience, but most importantly, we can better understand how we can help you. So with that, I'll turn it over to Jimmy.
Thanks, Christy. So in the case any of you weren't able to join our clinical data conversion webcast a few weeks ago, I just wanted to go over a few items in review to make sure everybody can stay up to speed during the course of our presentation. So at the highest level, a clinical data conversion is the process of extracting clinical data from one system and loading the data into another system. This is done via the ETL process, which stands for extract, transform, and load. Something you might hear us refer to over the course of today's presentation is the legacy system, and this is the system you are converting from. Conversely, the target system is the system that you are converting to. Galen has been involved in countless conversions, running the gamut of vendors. So just to list a few examples, we've been involved both to and from TouchWorks, Meditech, Cerner, Epic. We've also been able to work with a large number of smaller vendors that have been converted to the 4 previously mentioned vendors. Within that list, the types of data that we've converted has ranged from single data elements to entire patient records for as little as a few years, but all the way up to the legacy system's inception. So an overview of a conversion, the conversion really has 6 phases. The project design, extraction and data evaluation, data mapping, testing and validation, conversion go live, and the support and gap loads at the end that follow. So let's get started with the first phase, project design. This is where the scope of the project is defined, which is primarily done during the sales process. However, there are other considerations to make and greater definitions of scope to explore during the kickoff and also in subsequent meetings at the beginning of the project, such as what data elements to include specifically to support your reporting needs, and also what areas and data are needed as part of those elements. So for a quick example, when bringing over immunizations, what fields are needed to support related measures? Your manufacturer, the NDC, the administration date, these are all important things to think about when scoping, and that's just on the smallest scale. The timeline for the conversion also needs to be considered here. Depending on what your legacy and target systems are, there'll be a few different requirements that impact your timeline, such as extracting the data, loading the data, and then testing all of the converted elements. So next we have extracts. The technical analyst for the conversion will extract the data from the legacy system that's within scope and create mapping workbooks to associate legacy items to their direct counterparts in the target system. Many decisions need to be made around the extracted data before it can be mapped, though. So for example, if there's a field in the source data that does not exist, or maybe it reflects differently in the target system, this must be accounted for, and a plan must be put into place as to how it's going to be dealt with and loaded properly in the coming weeks. After that, we move to data mapping itself, which is pretty self-explanatory. Each data element from the legacy system in scope will need to be mapped to its counterpart in the target system for basically, or what we hope to be, a seamless integration of data from one system to the other. Okay, so after data mapping, we have testing, validation, and issue resolution. So in the scoping process, it's important to define not only how many rounds and levels of testing will take place, but also who and what resources will be included in testing. So in the case of MU reporting, it's really important to make sure that enough MU-related resources are included in the testing process, not only in the target application itself, but also in the reporting modules to allow for issue resolution should data elements need to be adjusted before loading. Phase 5, conversion go live. So as with any other go live, it's important to make sure that you've defined a scripted process for how loading will go, and any action for a rollback that might need to take place. Within this plan, should also be included any relevant training materials, contact numbers, and a checklist/decision list that was defined throughout the project for any potential issues that were preconceived. Lastly, following go live should be support and gap loads. And this is for any items or sites that were still live on the legacy system and maybe are going to be brought onto the target system on a rolling or go forward basis. So crosswalks. When preparing for attestation during a conversion, it's important to understand exactly how your meaningful use reports are calculated. Not only should you understand what configuration pieces will affect those particular measures that you're testing for, but also how those configuration settings will hit your database. When clinically relevant actions are carried out, information is logged in the corresponding database tables Therefore, it's usually beneficial to construct a crosswalk between your two systems to make sure you know exactly what information you're pulling out of the legacy system and where you're going to load it into your target EHR. So as seen on the slide, a crosswalk will help you identify fields as they relate to measures. It will also allow you to make note of how the information populates from the EHR into the reporting database. And finally, using this information, you can compare similar info between the legacy and target EHRs. Alongside this crosswalk should be a document that defines the relationship between certain MU measures and the database tables that they calculate from. Together, these two documents will provide tremendous assistance, really, when trying to prepare for reporting out of your new target system. Now I want to turn it over to Drew, who will cover some technical recommendations for us.
Thank you for that, Jimmy. So now that we've briefly talked about the conversion process and the timeline requirements, we can now talk about how the data will actually be brought over. When thinking about converting data, it's important to know whether the data should be converted discretely or non-discretely. In regards to meaningful use, it is imperative to convert the data discretely. The reason for this is because it's impossible to report on data that had been converted non-discretely. A goal of a discrete conversion is to add the source data into the target system as if the data was entered into the target system by a user. This means that the source data will be aggregated with the pre-existing target data, assuming any exists at all, which can then be reported on. A discrete conversion will probably require the use of CCDs or HL7 messages. Since CCDs can contain all of the item types, such as problems, immunizations, and vitals, a common question is, what types of item types should be sent in an HL7 message versus a CCD document during a conversion? Or better yet, why use HL7 messages when CCDs can contain all of the item types? The answer to both of these questions completely depends on the EHR the data is being migrated into and how they handle CCDs. For example, Epic is currently able to read discrete problems, medications, and allergies from a CCD and add those to a patient's chart to be reconciled by a provider. Now the issue is, we still have immunizations, vitals, results, orders, notes, or scans that must be converted. In this example, Galen advises to sending allergies, medications, and problems via CCD, and everything else is HL7. However, for other EHRs, such as Meditech or Cerner, we recommend having a resource who works with the target system to figure out exactly which data types can be converted in a CCD, HL7, or by any other means. As stated previously, all systems are different and should be treated as such. Now that we've talked about some of the requirements for a conversion, we would like to open a poll to see whether you are currently planning on scoping for a future conversion project, yes or no. I will give you guys about a minute to answer this.
Okay. Well, now that we have yeah.
I was just going to say, we're still seeing some responses come in, so I was just going to give it a couple more seconds before closing the poll.
Perfect. Okay. All right. Well, while we are still doing the poll, I will just get started here. So thank you, Drew, and thank you, Jimmy, for doing that overview. But the question of the hour, will an EHR conversion affect your efforts to meet meaningful use? So it largely depends on where you are in your MU process, but it really should be among the topics considered before making a system switch. But if I was going to cut this whole entire presentation short now, my response would be a big no. And we can help you get there and understand exactly what you need to know. So depending on where you are in the attestation process, a conversion could cause you to miss opportunities to attest. This results in a huge reduction of incentive dollars that you'd expect if you don't follow the suggestions that we're going to outline for you today. We still have clients out there in all sorts of situations with their current EHR. If your current system won't allow you to achieve the next meaningful use stage, then the risk associated with the change may be one that you simply have to take based on the financial impact. So that begs the question, What exactly are your main reasons behind your conversion? We find that organizations that are focused on their long-term needs rather than their short-term incentives will always be better positioned for the future. Decisions are being driven by meaningful use, and of course, all the other incentive platforms, such as PQRS and patient-centered medical home programs, all remind us that replacing an EHR is kind of a short-term setback, but usually this decision will have a longer-term payoff. It's important to realize that there is a vision and a goal behind meaningful use that goes beyond incentive payments. Organizations that are looking at this quote-unquote big picture and not just focusing on installation costs and incentive funds will be the ones that are better suited for success. What I mean by this is it's just basic better care, and really this is what it's all about. So as Jimmy mentioned earlier with the discussions on planning, we realize the intensity and the thought that goes into this process. How long it takes to complete a conversion depends on the size and the scope of your practice, but it can really take up to a year or longer to go through the entire implementation cycle. So this will include all sides of the workflow analysis, custom development, training, testing, validations, the actual go-live support. The list goes on and on. So when I start to list out all these things, of course, budgeting comes to mind. How much of these subjects do we need to focus on to be successful in both projects? You've got the conversion as a whole and maintaining your attestation. So budgeting can make or break a situation for you. So how worthwhile is it to postpone your attestation in order to convert to an EHR? Well, let's ask. Are you realistically ready to roll out workflows after the conversion that focus not only on just seeing patients, but also are you engaging your staff on learning what it takes to meet your quality incentives for CMS? If you budget in properly for training and workflow development, you can successfully do both. So as we discuss the methodology for rolling out an attestation from two different systems, you'll see how important it is to immediately start capturing meaningful and discrete data the day you go live. Everything your users do in this new system will need to be used in the final percentages that you're going to be submitting. So there is, of course, no easy answer to deciding upon a conversion. The key is to have the transition done right by qualified organizations. So we here at Galen, we're well suited, we've had solid implementation approaches, and of course we always sync with your personalized schedule and your environments. The project requires a detailed plan and a full team managing that process. So with that said, let's talk about the resources that you need and what we need them to help with. So the one secret to making everything flow every day that you come to work is your users. Keeping your resource satisfaction high, training your providers to always capture discrete data, and putting less load on your help desk resources and maintaining high compliance among your staff takes a lot of work. Training, training, training. When you go through this conversion process, a lot of emphasis should be put on this subject. Training your users to not only use the new application, but to use it in a meaningful way will be much easier than the process that you have undergone these last few years. On day one, when they log into that new system, it should be that they know it just as well as they did the old system, and I even recommend even better. So you've gone through upgrade after upgrade, years of workflow modifications, special package installations, and things have started to really get complicated, and your users have definitely suffered. So this being the case, we see time and time again, I can trust that many of your users just don't want to keep adjusting how they do things. Most of them have the speed down and they're capturing what they need, but they're uneducated on the new pieces of data that now need to be captured for these later stages of meaningful use. And I'm not going to lie, when I worked directly on the floor as part of an intake staff, when we noticed how far behind we were, how upset the patients were getting, all we cared about was getting them room to see the doctor. And you can't possibly manage to attest successfully with these higher thresholds and more complicated measure criteria if your staff is thinking this way. It's got to be second nature for them to just click, 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 but to go easily through those workflows and not have to second guess at any alternative methods, which sometimes those might be easier, but it lacks at capturing what you need. So we're going to use an easy example here. You have a patient who has hypertension, but they're only here for a quick INR check. What does that mean to your staff? Can they even decipher what type of appointment the patient is here for or realize that the patient has hypertension? If this resource has the proper training, they know instinctively that capturing the blood pressure for a patient like this is even more important than just 2 years ago. And I can almost say confidently that your organization is supporting attestation to upwards of at least 2 or 3 measures that check blood pressure. So that said, you got a budget for all these resources. When we talk about supporting big moves like a conversion, this often means that 25% of this should go into training. It's 25%. But for anyone who's been through a conversion, we know that this means serious consideration into who these resources will be and what your methodology will be for each and every department that's going to be impacted by the conversion, all of the attestation efforts in both. So you need to break this down a lot into different categories. Analysts who know not only how the legacy system is set up, but also why it was set up that way, and then what has been new in the past few years to meet meaningful use. Then you got to find resources that know your target system in and out in the same respect who understand the legacy system. Most importantly, then you got to train them to communicate efficiently. So once all the efforts have been grouped and all the affected departments identified, you'll find that this is pretty much inclusive of every employee that you staff. An EHR conversion and meaningful use attestation together takes a lot of organization, a lot of training, and above average communication amongst your staff that trickles down to all of your end users. That's what I'm going to consider step one. Step two is now to identify anybody who's knowledgeable about the attestation process with CMS. These resources will need to check your registration status and know what next steps need to happen for the actual submission. So I'll go into that here next. So now that we've engaged these quote-unquote attestation staff, there's a few steps that we now need to be aware of for submitting your current stage data. First, you're going to need to register again when you switch vendors or practices. You can check your current registration status by logging into the CMS registration and attestation portal. I put this website here for you, and we'll have these slides posted afterwards so you can locate that page. The registration status is imperative to CMS knowing where the data is coming from. If you're doing a rollout with multiple sites on different EHRs, we'll have to train these staff members to be aware of what sites have gone live on the new EHR and update only those providers' registration status. So because meaningful use is provider-based, at least for most of our clients, when we attest per EP, the user that is submitting that provider's final data will need to know from what certified product the information is coming from. For example, if you sent in data last year for your final year of stage 1 and you were all on the same EHR, you'll have to renew your registration when you submit stage 2 information for the same provider who's now on a whole new EHR. Well, it sounds easy, right? Well, it depends on your conversion process. That easy scenario would only be if you went live on January 1st for your entire organization. And I think we all know that that never happens. What normally happens is this multi-stage rollout in which various sites throughout your organization all go live at different dates throughout the long timeline. For this reason, you can have a doctor registered in 2 different EHRs through CMS. Dr. Logan, for example, is a provider at a site that went live on Epic from Allscripts on May 1st of this year. So how do we submit Dr. Logan's data from January through May when he was on one EHR, as well as for the remainder of the year when he was on a new one? Well, a side note, I'm not going to go into it too much, but here's one of those great debates in favor of stage 2 only being 90 days versus a full year. The timing of these conversions and upgrades, implementations, and all your other projects would be a lot easier. So instead, getting this whole year's worth of data just makes things a little bit more complicated. So that's why we're breaking this down for you today. So I'm going to break into a little easy example, and it's not as hard as you would think. So for objectives that require a simple count of actions, so for example, the number of permissible prescriptions written or the number of patient requests for a copy of their health information, the EP submitted data can be calculated by simply adding the numbers from each system in order to arrive at a total for your numerator and denominator for that one measure. Then you have objectives that require an action to be taken on behalf of a percentage of unique patients. So those are your record demographics, record vital signs. This is the same thing. The EPs may also add the numerators and denominators calculated by each EHR and then get a total for the numerator and denominator, just like we mentioned above for the numbers. So side note, and of course we should know this regardless if you're going through a conversion or not, keep in mind that any patients whose records are still not maintained in a certified EHR will need to be added to the denominator so your numbers are still accurate. So this will be any offices that are using alternative EHRs or maybe even paper, anything that's just not certified. But that's what we're here for today. Both as an attendee learning about your options as well as from the perspective of a consultant here at Galen, it's to absorb and learn your unique situation and modify a plan to help you achieve successful conversion as well as to maintain your attestation. That said, I think that we know that there's multiple scenarios that are not as cut and dry. Oftentimes we find providers who practice in multiple locations within the same organization. Maybe one of those locations is on one EHR and the other has moved to the new EHR. Attestation data will need to be calculated and added together exactly as we mentioned above. Some measures, of course, are not going to be so easy. So when we report on clinical quality measures, all the EPs who practice in multiple locations should generate a report from each one of those systems. Then add in all your numerators, denominators, and of course including your exclusions from each report in order to arrive at a number that reflects the total output of patient encounters at all locations, just as above. So it really isn't that complicated. I think the hardest part circles back to communication and training. So the resources who are working the submissions to CMS must be aware of exactly where the data is coming from and for what dates they'll be adding data together from. So when you go live on a site during your conversion process, don't overlook these points. You need to be responsible not only for the calculations, but also the collection of reporting data for auditing purposes. You're going to need screenshots for supporting documentation and very well documented information on any of your exclusion measures. So that said, I'm just going to take a quick pause, turn it back over to Drew for a little poll and find out where and if you guys are doing any conversions.
All right, thank you, Christy. So for those of you planning a conversion, what is the timeline for your going live with your new target system? Is it 1 to 3 months, 4 to 8 months, 9 to 12 months, or 13 or more months? So we're still getting a few responses, so we'll just hold tight for a little bit longer.
Thank you, Drew. Okay, so now I wanted to talk about where we need to do a little comparison of the two systems. So now that we've taken time to discuss resource allocation needs, the training and attestation methodology, it would be silly not to mention the gap analysis that we need to do across your legacy and target systems. The gap analysis will focus on doing a comparison of actual performance data, basically what percentages you've been getting, and then comparing it to your desired potential. So in short, we look at workflow trends and how to configure and take advantage of a new system. So we do this by rolling out new workflows that increase percentages for measures that may be currently lacking. You could even utilize the stage to roll out additional workflows to help meet CQM measures, PQRS measures with higher than predicted percentages for next year. What that means is that our work is to determine all the missing pieces to meet the measures and take advantage of the training to ingrain these new workflows into your staff. Where they'll be learning a whole new system anyway, we might as well leap on board and create a workflow that helps everyone, the doctors, the nurses, and most importantly, the patients. But we need to stop and think about what we're really doing here. You're converting to a whole new system. You've taken years and years to develop, configure, and live and breathe your current EHR. And now what? You just move to a whole new system and come to work on Monday? Unfortunately, it's not that easy. Some would say, sure, it wouldn't be that bad. You add in all of the thought and process level configuration, everything that went through steering committees to change control committees, through a board of super users and providers, all for insight into why you made certain decisions. So shouldn't the same amount of thought go into this next one as well? Shouldn't all the meaningful use measures, PQRS, clinical quality measures be implemented in the same way? So please go back and assess your workbooks for build decisions, the coding requirements, and all the proper securities to ensure that your teams managing the two systems are communicating effectively to make this work. It really can't do too much if a new workflow gets rolled out, trained perfectly, and then come time to assess your calculations for MU, you're failing. And why? All because a code or specific order was overlooked? When configuration is being done on your target system, I cannot stress enough the importance of putting your system analysts and meaningful use experts together in a room to make the process the most efficient and streamlined process that you can. But as we move forward with your new EHR, it's also important to note that the ongoing maintenance of your data is important. As we discussed earlier, you need to keep everything. And I mean, in all sense of the word, you need to hoard your data from your legacy system in order to successfully attest, pass an audit, and meet state regulations on data storage. You, of course, will need all the same documentation kept from your new target system, but if you're going live in February, keeping all that January data still becomes extremely important. So there's some links at the end of the presentation that will assist you if you have any questions on that auditing process. So more so, you need those saved reports with MU data for submission a year later, as we discussed. Screenshots and failed attempts are no exception. They're still legitimate numbers that CMS will require of you. Maintain these records and keep them safe and accessible as all of those from your new environment. So when we speak of data storage, I don't mean just by the way of space from a technical perspective. What we are trying to concentrate on are the actual attestation folders, what you need and for how long and why. So to start, what do you need? You already saw that link provided earlier, but here's some of the basics for you. Providers who receive an EHR payment for meaningful use potentially may be subject to an audit. You should retain all relevant supporting documentation, so that's either paper or electronic, that was used in the completion of all of the attestation module responses. So documentation to support attestation data for meaningful use objectives and CQM should be retained for 6 years post-attestation. It's the provider's responsibility to maintain documentation that fully supports the meaningful use and CQM data that's submitted. An audit may include a review of any of the documentation needed to support the information that was entered in the attestation. The level of the audit review may depend on a number of factors. However, the following will outline the minimum supporting documentations that providers should maintain. So the first one is called the source document. This is the primary document that will be requested in every single audit or review. The document should provide a summary of the data that supports the information that was entered. So ideally, this would be a report from your certified EHR system, but other documentation will be used if you don't have a report available. Providers who use a source document other than a report from the EHR to attest should retain all documentation that demonstrates how the data was accumulated and calculated. This primary document will be the starting point of most reviews and should include, at a minimum, the numerators and denominators for the measure, the time period that the report covers, and the evidence to support that it was generated for that EP. The second one is any documentation for non-percentage-based objectives. Not all EHR systems currently track compliance for these non-percentage-based objectives, so these are the ones that typically require a yes attestation in order for a provider to meet MU. So to validate provider attestation for these objectives, CMS may request additional supporting documentation. Each measure will have a different subset of supporting documentation that I recommend that you become familiar with. And then, of course, lastly, are your exclusion documentation. You'll need to support each exclusion to a measure claimed by the provider. So a report from the certified system that shows a 0 for the measure, or any other documents that the provider qualifies for the exclusion. And now, how long do you need it? When going through a conversion, this is actually a biggie. So once your entire organization is now live on your new target system, you'll want to pretty much just discard any remnants of your old legacy system. But I urge you to maintain this environment and safely store all of your last state reporting calculations. Running reports and capturing data on your last day of production in this environment is crucial. As we discussed, you'll need these numbers to calculate a final tally on your numerator and denominator counts. Access to your reports can sometimes be available long after you stopped using that EHR, sometimes at a fee, but it must be maintained and properly discussed with your individual vendors. So as stated, you'll need this data for at least 6 years for the Medicare meaningful use period, but there are variations in this time standards for all quality incentive programs, as well as for Medicaid attestation, that you should follow up with each individual states on that. So in conclusion, I first just want to thank you guys all for listening today. I know that was a lot of information. I know that I've grown. I know everybody here at Galen has grown to just relish in assisting our clients through these conversions. And sometimes it really just does go overlooked how much thought and process needs to go into a fully successful conversion. We're not here to help you just simply map data to your new system, but also recognize the importance of our consulting practice as a whole. Our experience in the numerous quality reporting initiatives can be utilized throughout your organization to keep all your analysts on the right track during their configuration. To keep your change policies directors on point when making workflow updates to support these measures, And we'll be here to help manage these projects in coordination so that your entire shift to a new EHR can be successful. So I encourage you to come back and check out our newest listing of products and services that have been developed. Just last week, I spoke on another webcast with a fellow Galen resource, Matt Hoover, who developed a reporting tool that will help pull all of your reporting data from any system, Allscripts, Meditech, Epic, for any of your PQS reports. This tool is really helpful to help watch and monitor your numbers during the conversion. Highlighting those gaps and finding where numbers are shifting downwards just as a result of the conversion will be key in updating and maintaining your training to all of your users. So I guess what I really want to conclude with is it's a really long process, and it's packed with a lot of attention to detail. Just doing a conversion is not quite enough to call the shift successful. You're only successful as your population of healthy patients and happy staff members. So changing to a new EHR is stressful. It's going to impact a high population of your organization. So I guarantee that we can help. So in all, thank you guys all for your attendance today. We're going to leave you with one last poll. And as you can see here on this last slide, there's a few resource links here. Check them out. I guarantee that they'll have a few extra little tidbits of information for you. So thank you again, and I hope you all have a great weekend.
All right, so our final poll is, would you be interested in talking with Galen about how we can assist you with your conversion and meaningful use reporting needs? Yes or no? I'm going to leave this poll open for about 5 minutes. Thank you all for joining. All right, it appears everyone has answered, so I'm just going to close the poll now. Thank you very much.